Hi, everyone, and welcome to OT Echo. Today is January 9th, 2025. This is our first presentation of the new year. And I just want to say thank you to everyone for being here and being dedicated to continuing your education. Today, Joseph Nshimiyimana is going to be presenting to us, and he is one of our members. So I'm just so excited that we are sharing our knowledge amongst each other. If you would all remain on mute, and just remember that you need to complete the pre-survey and the post-survey to receive a certificate of attendance. And the post-survey will be given to you at the last 5 minutes. All right, well, Joseph, why don't you give everyone an introduction and tell us about what you're presenting on today?
Okay, thank you. I'm Joseph Nshimiyimana, as I said before. I'm currently a assistant lecturer at University of Rwanda for 2 years, and I've also experienced working in physical rehabilitation and at a hospital whereby I provide occupational services for people with a neurological condition and children with developmental disorders, mainly cerebral palsy, for 2 years also. And also I have 1 year of experience working in a special school where there were the children with mental disorders and other behavioral problems at school, and I facilitate the learning and also the rotation in participation, everyday life activities at home, and even participating in AD at school. And my research interest is based on disability and rehabilitation, neurological rehabilitation, and also mental health in adolescent at school and mental health of workers at workplace, and also in geriatric rehabilitation. This is my area of interest in research. As a researcher, I'm interested in doing this research as well. I have masters in rehabilitation. So this is my area of interest. Thank you. So today's topic is about traditional neurophysiological approaches versus contemporary neurophysiological approaches. And you will see some of the important things like I'm showing you here on this outline. You see different key terms and different traditional neurophysiological approaches and the contemporary physiological approaches. Okay, let's start with just having an overview about these traditional and contemporary neurophysiological approaches. So tradition means old, something which is practiced in the past. Contemporary means something which is current, which is modern. So when we say neurophysiological approaches, it means the practical theories aimed at understanding the function of the brain, means the central nervous system and peripheral nervous system. So these approaches leverage the concept of brain plasticity, which refers to the brain ability to adapt and reorganize its structure and function following the damage. So by applying these principles or theories, the practitioners guide individuals with neurological disorders in retraining and performing specific tasks or motor activities by facilitating recovery through neuro organization and plasticity. For instance, when you are treating a stroke patient, you might train the affected arm to optimize the function of the hand. So through training the hand in tasks that the patients are unable to do, you are training the brain to adapt to the new function through practice. So this practice of rust skills are based on these neurophysiological theories or neurophysiological approaches that we're going to see in detail. So when I say traditional neurophysiological approaches, are those theories that are used in the past, are old theories that were guiding the practice in management of the neurological disorders. So these theories that are old are reflex and hierarchical theories. So under these theories, there are main approaches like neurodevelopmental treatment, proprioceptive neuromuscular facilitation, and others that you see down. So when I say contemporary neurophysiological approaches, it means that are those modern theories that are guiding the practice or the management of the logical theories. These theories support development of different current approaches like task-oriented approach, CIMT, constraint-induced movement therapy, and Miller therapy. Those are the approaches that are based on the modern theories of practice in management of the neurological disorders. So now let's start with traditional neurophysiological approaches. So number one that I'm going to start with is proprioceptive neuromuscular function, which is PNF. So this approach was developed by Dr. Herman, Dr. Margaret, and the Los Vossi. Those are the pioneers of PNF. So in the starting, in the era of 1940s, this approach started as proprioceptive assistance. But in 1954, Dr. Dorothy included the words neuromuscular to deliver pleasantly familiar proprioceptive neuromuscular facilitation. Then later in 1956, Dr. Margaret and Dorothy published the first book of PNF. So can see this book online and can see more detail on PNF, whereby there are different PNF techniques and PNF patterns. Can read more on all those theories and practice. So PNF approach emphasize that the impulses from the peripheral are facilitated to the central nervous system through the stimulation of sensory receptors present in muscles and along the joints by strength, resistance, traction, approximation, and audiovisual. So this is the approach based on the reflex theories, which means that there is the movement because of the stimuli. So these stimulus should be provided to the muscles, joints by stretching or traction. So through this stimulus, there should be a production of the movement. The patient should learn the movement through traction, joint approximation, and these stimulus are transmitted to the central nervous system just to give a response, which is a movement. So that was all about the PNF in summary based on the traditional theories of neurophysiological approaches. So another traditional neurophysiological approach is NDT, or neurodevelopmental therapy. Also, it is called Bobath approach. So this Bobath approach was developed in 1940s. Actually, in 1940s were the era of development of the approaches which help in the management of neurological disorders. So I asked myself, what were before these years used to manage neurophysiological approaches? So I think it was very difficult before these theories being developed. So Bertha Bobath, who was a physiotherapist and a husband Kerr, who was a neuropsychiatrist, developed another approach in this era of different neurophysiological approaches. So this approach is used just to manage neurological disorders like cerebral palsy, cerebrovascular accident, or stroke. It focuses on inhibiting abnormal movements and facilitating the normal movement through therapeutic handling. So Bobath believed that it can facilitate the motor running through handling. For example, on this picture, a therapist is facilitating the child to participate in activities in a standing position by locking the knee, okay? By locking this distal key point of control, which is knee, a child should participate in tasks in sitting position. In picture 2, a therapist is facilitating half-kneeling by combination more than one key points of control. A therapist is supporting the hip and the shoulder to facilitate a client to maintain the half-kneeling position. So this position will facilitate this client to get in standing position. So Bobath believe that these theories believe that the changing function at muscular level, but Bobath hypothesized that the disorder of coordination of posture and movement is what prevented functional performance. Okay. Before this theory, they think that the limitation in performing a task is enough just to work on muscles, okay? But with Bobath, there is a new theory saying that the connection of posture and movement, okay, should facilitate a functional performance, should also prevent a functional performance when the posture and movement are in abnormal patterns. Then Bobath introduced the revolutionary idea that therapies could have an impact on clients' functional movement by influencing the central nervous system through careful guiding the motor output through handling. According to Bobath, through handling, by using the key points of control, either proximal key points of control and distal key points of control, should facilitate the functional performance. So Bobath is evolving day by day. So now we're going to see a different evolution of the PNF or NDT. So in the beginning of development of Bobath, it was an approach based on reflex hierarchical models, which means that this theory in the beginning believes that the movement is emerged because of the reflex or stimuli, and the higher centers control the lower centers. When I say higher centers, I mean the cerebral cortex, and lower center means brainstem and spinal cord. But currently, this approach is based on a system or selectionist model, which means that the movement is learned or is produced depending on the various systems: musculoskeletal, brain, sensory system, and even the environment. However, before that, it is only based on the control of the central nervous system. And also, in the beginning, they believe that Bobath, the movement emerged because of the hierarchical model of central nervous system structure function, but currently it is distributed model. This means that in the beginning, they believed that the movement is controlled from higher centers to lower centers. Okay, the cerebral cortex, brainstem, and spinal cord. For example, the cerebral cortex involves in the voluntary movement. Then the brainstem involves in the reflexes. Brainstem and spinal cord involves in the reflexes. But the current theories of NDT believes that there is a distribution of the function. There is the connection of different brain regions which work together to produce a movement. It is not only the cerebral cortex which should involve in the voluntary movement. There also be some connection or working together with the brainstem and spinal cord to produce the movement or to run the movement or motor patterns. So in the beginning, Bobath believed that the CNS viewed as the controller, but currently CNS determines a pattern of neural activity based on input from multiple intrinsic systems and extrinsic. So in the beginning, Bobath believed that the central nervous system is a master of N movement, N motor patterns, N motor running, N motor production. But today's, the motor running, the motor production depends on the many factors: the contextual factors, the intrinsic factors, and other extrinsic factors. So also in the beginning, this approach based on assumption, which is that sensory feedback is important for correction of movement errors, which means that the sensory feedback means the information from the sensory system. When there is a stimulus, for example, on the sensory receptors and the joints and the muscle spindles, like in the muscle spindles, it should give the information to the brain, which should respond by collecting the movement. But today, even the sensory feed forward is important. Sensory feed forward means the production of the required motor patterns based on the previous experience. For example, before getting the stroke, I was able, for example, to pick the curb. So with that experience that I have before, I should have that patterns of movement. Together with feed forward, together with a stimulus. Okay? Should combine both feed forward, those reduction of movement patterns that I had before, with a stimulus from sensory inputs, then I can perform a motor pattern or different performance activities. So before, they believed that NDT is based on positive signs, just on spasticity, on abnormal movement patterns. Those were the positive signs. For the negative signs, also taken into consideration for the kind theories, like include the weakness of muscles, impaired motor control, would also be taken into consideration that should impact the movement. So lastly, this BOBAF in the beginning involves in muscle and postural tone, which determine the quality of patterns of posture and movement used in functional activities. But currently, the task, the experience, individual learning strategies, movement synergies, energy and interest, all should affect the quality of final action, should affect the quality of motor pattern of the patient. So those are all about BOBAF or neurodevelopmental therapy. Let's go to the Margaret Rhodes approach. This is also one approach of the traditional neurophysiological approach. So Rhodes' approach is also based on reflex hierarchical theories of central nervous system development. And Margaret was physical and occupational therapies at the same time. The essential concepts of this approach involves motor patterns development through sensory stimuli based on primitive reflexes and normal motor development patterns to progress performance skills. So this approach guides the therapists in finding motor patterns with the theories that when there is a stimulus, there should be a movement. Okay. For example, you should now stroke in the hand of the child just stimulates the flexion or the grasping of an object. Through this stimulus, there is a movement in the hand. And based on the normal motor development patterns to progress motor performance skills, for here, you should train crawling for the child just to prepare walking. That is hierarchical theories, okay, or proximal to distal theories. Means that the learning of the movement start from proximal, okay? Neck control, trunk control, sitting, crawling, then the child can walk.
Excuse me, Joseph, I just want to give you a 5-minute warning that we'll need to move to the case study.
Okay. So these are the theories based on Margaret Lord's approach. This is the sequence whereby learning a movement is based on reciprocal inhibition, co-contraction, heavy work, and scale. Those are the techniques. You have facilitator technique, proprioceptive facilitator technique, and proprioceptive inhibitory techniques. So this is a Brainstorm approach, which is also part of the traditional neurophysiological approaches, which is developed by Brainstorm, and it has 7 stages. It is mainly involved in the management of stroke patients, whereby in stage 1 it is flaccid, stage 2 involves synergies, start to receipt. Stage 3, there is beginning of voluntary movement. Stage 4, there is beginning of spasticity. Stage 5, there is increased control of selective movement. Stage 6, isolated motor control. Stage 7, there is high performance or coordination of motor movement. So now let's go through first on the contemporary approach. So this is currently used in many practices here while you are working on task training. So some theories and assumption of this contemporary involves motor learning development depends on many systems: brain, skeletal system, muscular system, environments, physical, social environments. Normal development is the search for optimal solution to functional problem and does not follow a rigid sequence. Motor learning is influenced by a number of repetition, practices, and the context. Practice tasks under variety of different conditions. Patient is actively participating in the therapy. The therapists use the task activity that is usually involved by the patient in his or her everyday life. When you are being treated by using the familiar task or activity that you used to enjoy before, facilitate fast learning. So motor development occurs based on the interplay of 3 factors: individual, the environment, and the task. Repetitive practice matters by making the practice specific and detailed. Mental rehearsal, processing the skill over the mind. There is appropriate use of teaching strategies of technical knowledge. While using this contemporary approach, specifically task-oriented approach, you might use the appropriate teaching strategies because you are training the patient to run the skill. You need to break down the tasks. You have an activity, then you break down every step of the activity just to make run more easier. So there are different stages of running. Stage one, which is cognitive phase. At this stage, the client tries to understand the requirement of the task. Phase two, which is associative phase, the client compares or associates her current level of performance with expert demonstrations or the therapist's demonstrations. The performer at this stage or the client may use more trial and error to overcome such deficiencies. At this phase, the client should make some errors until he's learning the correct motor patterns. So this is the stage 3, which is autonomous phase. This is the final phase of learning, occurs when the client has reached at an expert level of competence due to length of practice. This is a phase where a client can do a motor pattern independently. And this level is reached depending to the time of practice. The more you practice, the more you attain the skill and you maintain for a longer time. So this is a summary of traditional and contemporary neurophysiological approaches. So for traditional neurophysiological approaches, we have PNF, NDT, Lutz approach, and movement therapy, or Bronsstrom approach. For contemporary, we have task-oriented approaches. Traditional is based on reflex hierarchical theories. For contemporary, incorporates more theories, motor running theory, dynamic system theory, ecological theory, and motor programming theory. Traditional focus on the impairments, while contemporary focus on functional activity or task. Traditional is less emphasized on neuroplasticity, while contemporary puts more emphasis on neuroplasticity. With traditional neurophysiological approach, a therapist directs interventions. It means that the client acts passively, while a therapist is more active. So in the contemporary neurophysiological approaches, a client is actively involving in therapy. When you're performing a task, you let the client expose his or her potential to participate in a specific task. So thank you. This is all about for this presentation on traditional and contemporary neurophysiological approaches. This is a reference for more information. Yeah.
Great. Thank you so much, Joseph. Would you like to go and present the case study?
Yes. Okay. Do you have it?
I do. If
So
you want to stop sharing your screen, I can pull it up on mine.
yes, yes.
Okay, can everyone see it?
Yes, I can see it.
All right. Joseph, do you want to go ahead and read it?
Yes, yes, can read. This is a case study uh, from, for, just for Mr. B, who is 65 years old, male, was admitted to the intensive care unit following hemorrhagic stroke. The stroke resulted in left-sided paralysis. During his 5 days staying in intensive care unit, Mr. B was in the acute phase of recovery, characterized by significant muscle weakness, flaccidity, and low muscle tone on the affected side. He was unable to initiate any voluntary movement during this period. After 5 days, Mr. B was transferred from the ICU to the neurological ward as his condition stabilized. He began to demonstrate some improvement with the ability to initiate slight movement on the left side of his body, which is the affected side. So the question to brainstorm or discuss for this case study, question 1, what impairment does Mr. B present and how might this impairment limit his ability to perform daily activities? Question number 2, which neurophysiological approach would be most appropriate for managing Mr. B's condition? Provide example and explain why for your choice. Question number 3, how do traditional and contemporary neurophysiological approaches differ in their application to the management of neurological conditions? Use the case study of Mr. B.
Great. Okay, thanks everyone. And now Kelsey is going to break us into groups so that we can discuss the case study. Welcome back, everyone, from the breakout rooms. I hope you had a great discussion. So let's see what everyone said. So the first question was, what impairments does Mr. B present, and how might these impairments limit his ability to perform daily activities? Adonis, do you want to start with your group?
Sure. Well, we mentioned the weakness, the muscle weakness, and the difficulty in engaging in ADLs, like dressing, sitting from standing, toileting, and generally reducing of participation in occupations.
Great, thank you. Potian, did your group have any additional thoughts? I'm not sure if he's frozen. Tolu, how about your group?
Great. Because most of the things that you mentioned, basically on the self-care, communication, and someone also mentioned about the cognitive aspect of the patients was not really mentioned. So something to look into, like using assessment charts and then mobility. So on that, that's it.
Great, thank you. Joseph, if you have any comments, please feel free to step in as the presenter. Otherwise, we will move on to question 2.
Yeah, they just said that this is a time for questions. They should ask questions.
Okay, so the next question was, which neurophysiological approaches would be most appropriate for managing Mr. B's condition? Provide examples and explain why for your choice. George, do you want to tell us about your group's discussion?
Yeah, I should.
Yeah, thank you so much. The approach we can use for the case study we have seen, the first is NDT. I choose NDT because it helps to normalize the muscle tone of the left side that are affected. And in NDT, we have technique of stretching that help that people have that the left side affected to stretch that arms in order to engage in grasping and releasing. Thank you.
Great, thank you. Timothy, did your group have anything to add?
Well, Kate, our group looked at the weakness of the muscles, whereby we took the task-oriented approach as a means of addressing mostly the ADLs, whereby we look at things to do with feeding using maybe a fork or something, then bathing using the affected limb, and then dressing, whereby we do some buttons and what. Yeah, so that's where our group touched.
Great, thank you. David, what about your group?
Our group focused on two things. One thing was the different types of treatment that the therapist is most comfortable with. So there might put more emphasis on that rather than the other ones. The second one is that during the early stages, when the person is flaccid and doesn't have movement, you might use some of the stimulation techniques to get the movement started. And once the movement is started, then you could use some of the task-oriented techniques to facilitate more movement.
Thank you. Blessing, how about your group?
My group basically focus on dressing, retraining ADL for the patient, which include dressing, bathing. Then also they also classify him to have hemiparesics as his condition. Then also we move into him having hemi neglect when he's unable to carry out his activity fully. Then after being out of the ICU, we look into him being able to engage in activity, rating the muscle strength. The muscle strength was rated into level 2, which is grade 2. Then ability to build up the muscle strength using a contemporary approach, sensory brush. Then they also discussed about, we also discussed about using mirror therapy for the patient to use the unaffected arm to train the affected arm by moving the limb into different direction or positions, and also using Bobat theory or Bobat approach for the patient as well, for the abnormal movement, for the patient to be able to learn new gait pattern, new movement pattern, and be able to build up muscle strength and ability to carry out daily activities. That was what my group discussed about.
Thank you. Sounds like it was a good discussion. All right, let's move on. We have a few minutes left for that last question. How do traditional and contemporary neurophysiological approaches differ in their application to the management of neurological conditions? Back to you, Adonis.
Well, we discussed that during the contemporary approaches, the patient is more active versus the traditional ones where the patient is more passive.
Great. Talu, what about your group?
I think it's a similar. Mostly we feel my group members feel that contemporary approaches is more it's more beneficial to this patient since it's going to help to initiate activity that patient is interested in, and it's going to help to get more outcome with that contemporary method, and especially with the fact that they can utilize the use of assistive technology to help in assist some of these activities. So overall, we just think the contemporary method is something to. Oh, sometimes also it was suggested that they can also combine some of this method to ensure that patients' desires are being fulfilled. I mean, whatever their most important role, including their ideals and work area, can be focused on using those methods combined.
Great, thank you. Well, we have 1 minute left. Joseph, do you have any last thoughts or comments that you'd like to state about the discussion today?
Actually, I do love the way they brainstorm the case studies questions. Actually, they got the point of this presentation. And what's more point I want to add, while comparing the traditional and the contemporary neurophysiological approaches, the one which is most effective depends on the management or the need of the clients, the problems that you want to address, and even the experience of the therapists. Maybe one therapist is experienced on using NDT, another one is experienced on using task-oriented approaches. So it will be a different for those two therapists, depending to the experience. However, there is no one enough approach. They just advise the therapist choose more than one approach, depending to the problems.
Great. Well, thank you so much, everyone. I really appreciate everyone being here for today's OT Echo.